Party Parliamentary Group on Smoking and Health, together with our counterparts in the All Party Parliamentary Group for Baby Loss. And I welcome all those members of the APPG, and in particular I will be passing obviously on to their chairs in due course for their presentations. First and foremost, just a piece of housekeeping. If you're not presenting and you're not on the speakers list, could you make sure that you're muted? And then if you've got a question, please put it in the chat section. And then when we come to the Q&A, obviously we'll take people from that and invite you to unmute yourself. But it just helps for all background that we don't have people unmuted and extraneous sound coming through. The meeting is being recorded, and the recording of the event and the presentations will be available from the respective APPG web pages after the event. It'll be a little time, I will wait for that to be put up. And we will also circulate a link to the report to all the participants on this call. And indeed, if there are people that colleagues wish to have notified about the presentation and the report, then please do let us know through the chat function. That'd be very helpful. Now, the Q&A will take place after all the presentations have concluded. So please, as I say, put your questions in the chat function. If you need guidance on that, it's a very simple job on Teams. So just type in your question and then we'll come to you at the appropriate moment to invite questions. So I think we're very pleased that we're having this joint meeting with the All Party Parliamentary Group on Baby Loss, and I welcome the co-chairs Jeremy Hunt, who of course is also the chairman of the Select Committee on Health and Social Care, and of course was Secretary of State. And I remember lobbying him very hard on the issues that we're going to be discussing later on this afternoon. So I'm not sure if he's a poacher turned gamekeeper or the other way around. And also welcome Cherilyn Mackrory, MP, who has recently joined, obviously, Parliament, but is already making a great headway, and thanks to her. Now, this isn't the first joint meeting that we've held. I do remember we held a joint meeting in 2017, where we launched a report from Action on Smoking and Health and the Smoking in Pregnancy Challenge group on smoking cessation training for the maternity workforce. Now, there are many reasons for baby loss, and I'm not going to go into those, but one of the leading modifiable risk factors is definitely smoking, something that both all party parliamentary groups are keen to see ended. And so we're also delighted to welcome today, as I did to our previous joint event, the Public Health Minister and Shadow opposite number, and I look forward to them addressing us later. Now, our 2017 event was the day the Minister's predecessor, Steve Bryan, launched his tobacco control plan and set out the ambition to reduce rates of smoking in pregnancy to 6% or less by 2022. And it's worth noting that of all the targets the government has set over the years on smoking cessation, the one that's been most difficult to achieve, I think, is reducing smoking in pregnancy. And that I think at the last time of the launch of the control plan was still stood at a stubborn 11%. So with 1 year to go to meet this challenging ambition, we're here to launch this new report from both all party groups, reflecting on the progress that's been made and the work that we still need to do to deliver that ambition. And Joe's recent announcement that a new tobacco control plan is being worked on and is expected to be published in July makes this report particularly timely. And I'm going to prompt Joe to say it is July 2021, isn't it, that we're looking at and not later. Those that have been in government, I think, will understand the concerns about how dates may slip. And these are difficult times. So COVID-19 has exacerbated health inequalities, placing additional burdens on poorer communities with higher rates of smoking already and worse health outcomes. So if the government is to achieve its smoke-free 2030 ambition, which I'm sure we all share, and truly level up society, it's vital we prioritise tackling smoking and smoking in pregnancy in our most deprived communities. Now, we know that reducing smoking in pregnancy is very close to Joe's heart, and I feel sure that it will be core to the next tobacco control plan, as it was to the last. So the recommendations set out in the report are firmly rooted in the evidence, and we would like to encourage the Minister and her officials to take them into account as they develop the next plan. And I just think we have to emphasise it's not just the mother or the woman that's pregnant who needs to be encouraged to give up smoking, but her partner as well. It's vitally important that both partners in this take the initiative to actually end their smoking habit for the duration of the pregnancy and while the baby is newly born, and hopefully that will lead to them to giving up completely going forward. So I'll now hand over to John Waldron, who's the Senior Policy and Public Affairs Officer at ASH, who is going to set out the key findings from the report. Over to you, John.
Great, thank you, Bob. Let me just hopefully share my screen. Can everyone see that?
Yes.
Perfect. Okay, thank you. So I'm just going to fairly quickly go over, our new report from ASH and the Smoking in Pregnancy Challenge Group called Getting Back on Track, Delivering a Smoke-Free Start for Every Child. Cool. Okay. And then, so the purpose of this report was really to understand why national smoking in pregnancy, or SATOD rates, I'll kind of use those interchangeably throughout, have only declined from 11% to 10.4% since 2015. And this is despite that government ambition to reduce SATOD rates to 6% by 2022. We'll also set out recommendations to inform the next tobacco control plan, which has been recently announced, maximise the impact of the NHS long-term plan, and get us on track to achieve a smoke-free 2030. So just in summary, I'm going to sum up the harms of smoking in pregnancy, the broader policy context, the key findings from the report, and the recommendations for next tobacco control plan. The full report is about 40 pages long, so I've really tried to heavily summarise it for this 10-minute presentation. So really quickly, who we are. Action on Smoking and Health is a public health charity that works to eliminate the harms caused by tobacco. And the Smoking in Pregnancy Challenge Group is a collaboration between academia, health professionals and maternity and baby organisations who kind of represent women and families. And our aim really is to communicate the evidence base to frontline professionals, stakeholders and policymakers to improve women's experiences in health during and after pregnancy. And of course, reducing smoking in pregnancy is central to this. And the group is jointly chaired by Dr. Claire Harmer, Chief Executive of SANS, and Professor Linda Bald of the Spectrum Research Consortium and the University of Edinburgh. And there you can just see some of the members of the challenge group, including the Lullaby Trust, SANS, Tommy's, and the Royal Colleges, and many others. So smoking or exposure to secondhand smoke during pregnancy is the leading modifiable risk factor for poor birth outcomes, including stillbirth, miscarriage, and sudden infant death, as you can see here. And exposure to secondhand smoke during childhood also increases the risk of a number of serious health conditions. As well as human costs, smoking during pregnancy presents a significant financial cost for the NHS, with pregnant smokers requiring more care and placing additional costs on NHS trusts compared to non-smoking pregnant women. And it's estimated that maternal smoking cost the NHS over £20 million in 2015-16. Rates of smoking in pregnancy also have a really strong social and age gradient, with poorer and younger women much more likely to smoke or be exposed to secondhand smoke during pregnancy. They're less likely to quit and more likely to relapse to smoking after birth if they manage to quit. And this is illustrated really clearly here, so you can see that women in the most deprived decile are over 5 times more likely to be smokers during early pregnancy than those in the least deprived decile, and this trend remains consistent throughout pregnancy. And similarly, you can see the same pattern for age, with younger women much more likely to smoke during early pregnancy than older women. High rates of smoking among younger, more deprived women correspond with significantly higher rates of infant mortality than the general population. So getting these rates down is really critical. So there's lots of national strategies that tie into this agenda. So there's the Tobacco Control Plan from 2017 that sets that 6% ambition. There's the Prevention Green Paper, which sets the ambition of making England smoke-free by 2030. There's the Maternity Transformation Programme, which includes a package of measures to tackle stillbirth called the Saving Babies' Lives Care Bundle, and reducing smoking in pregnancy is the #1 recommendation for reducing stillbirth in that package. And then, of course, you've got the NHS Long-Term Plan, which Misha Moore from NHSE is going to talk a little bit more about later, and I think the Minister's going to mention it too. So despite all of these strategies, rates of smoking in pregnancy are not falling as fast as they need to. So they've plateaued at just under 11% in 2015. And so although they're now coming down, they've only declined by 0.6 percentage points since then. And it's looking really unlikely we're going to achieve that 6% target, as you can see here. So there's a clear need to intensify activity to drive down smoking in pregnancy rates much faster. And this is critical for achieving the government's smoke-free 2030 ambitions, as well as saving babies' lives, which is the key message I want to get across here. So meeting that 6% target would also contribute to the national ambition to halve stillbirth and neonatal mortality by 2025. So the yellow line here shows the stillbirth rate since 2010 and the rate of decline needed to halve stillbirths by 2025, and the blue line shows the same for neonatal death. So you can see that although encouraging progress has been made in reducing stillbirth rates since 2010, neonatal mortality has kind of dipped and crept up again, so it's effectively flatlined during this period. So we estimate that securing the government's ambition to reduce smoking pregnancy to 6% would contribute between 8 and 13% of the reductions in stillbirths needed to meet the target, and between 2 and 5% of the reductions in neonatal deaths. Without reducing levels of smoking in pregnancy, these ambitions will be a lot harder to secure, leading to really tragic outcomes for many families. So why aren't national SATOD rates falling fast enough? So there's lots of contributing factors. There's significant regional and local variation in service delivery and outcomes in the NHS and in local stop smoking services. The number of pregnant smokers accessing stop smoking services has declined by a fifth since 2015. And in the same period, the number of adults in general accessing these services has almost halved. So targets to reduce smoking in pregnancy and create a smoke-free generation are going to be really difficult to achieve if these declines in people attending stop smoking services that help people quit aren't addressed. We really need to get more people through the doors of stop smoking services, not less. And then you have the public health grant for local authorities, which has been cut by a fifth since 2015 and has resulted in less funding for smoking cessation. Most areas have managed to retain support for pregnant women, but these cuts inevitably restrict how much support stop smoking services can provide. And it's really difficult to make services sustainable if they're constantly dealing with cuts. And then finally, smoking in pregnancy remains concentrated in younger, more disadvantaged groups who require really enhanced support to quit and aren't currently receiving that support on the kind of geography and the level required. Collectively, these all highlight a broader need to increase the numbers of women who quit smoking before they become pregnant, increase the number who quit during pregnancy, and then increase the number who are supported to stay smoke-free after their baby's born. So, although nationally those SATOD rates have declined quite marginally, regionally there's been a lot more variation, with some areas going much further and faster than others. So the northwest, the northeast and the east of England, as you can see here, have managed to reduce SATOD rates by much more than the England average, while other regions have seen smaller declines or even an increase. And it's clear that many of the areas that have seen sustained declines in rates of smoking in pregnancy are those with coordinated regional and local strategies. This isn't happening just by accident. And we're going to hear from Becca Scott about some of the really impressive work done in the northeast later on. However, it's worth saying that many of the areas achieving the biggest declines are those who are starting off with above average rates of smoking in pregnancy locally. So they have a lot farther to go to reach that 6% target. And even the regions with the best outcomes aren't bringing down rates fast enough to meet this target. This is largely due to high rates of smoking among the wider population, particularly poorer and younger women, many of whom will go on to smoke during pregnancy. Even the best maternity services and stop smoking services can't do this on their own. They really need to be backed up by a comprehensive strategy to reduce smoking rates before, during, and after pregnancy, with a specific focus on tackling those inequalities. So this regional variation is replicated at a local level. So this shows changes in smoking in pregnancy rates for NHS CCGs since 2015. And you can see that while almost half of CCGs have achieved declines in SATOD rates of 1 percentage point or more, in a fifth of CCGs, SATOD has actually increased by 1 percentage point or more. So you can see highlighted in red there. And the effect this has on the national figures is to kind of cancel out a lot of that progress made, and it helps to explain why those national level declines look so small. So while other factors such as demographic change do have some impact on SATOD rates, this visual is really helpful for showing where we need to target our efforts to improve the consistency and quality of services to get those rates moving in the right direction. And it also reminds us that this isn't an impossible task. Lots of places are doing this. We just need to see that progress happening across the whole system, so none of them are seeing increases. So how effective are services at supporting pregnant women to quit smoking? Now, there's no one good way to measure this, but of women in England who were smokers in early pregnancy in 2018-19, 16.5% went on to set a quit date with local authority stop smoking services, and 4.6% of those who were smokers in early pregnancy then went on to quit. And this varies substantially across regions. And it's worth saying that once stop smoking services get pregnant women through the door, they achieve better outcomes than 4.6%. We can see here that about a quarter of those who actually got through the door went on to quit. But as that 16.5% figure shows, getting women into the door is a big part of the challenge, and increasing that number would have a really big impact. The NHS long-term plan should have a really positive impact on engaging women with these services. So the report sets out 22 recommendations to address challenges across the system, and I'm not going to list them all here because there isn't time, but you can see them there. So I'm just going to focus on some of the key ones for the next tobacco control plan. So first and foremost, we've got the government needs to implement the recommendations set out in the Roadmap to a Smoke-Free 2030. So this roadmap sets out the action needed to achieve that government ambition of making England smoke-free by 2030. It was developed by public health organisations and endorsed by the APPG on smoking and health. And the recommendations in the roadmap are really about reducing smoking rates among the wider population, specifically the most disadvantaged communities with the highest rates of smoking. So this includes measures like the introduction of a well-funded tobacco control programme targeted to reduce inequality, greater investment in social marketing and mass media campaigns to encourage smokers to quit and link them with stop smoking services, and then also raising the age of sale for tobacco from 18 to 21 to reduce smoking prevalence in the age cohort that's most likely to smoke during pregnancy. So these are relevant because reducing smoking rates among younger, poorer smokers is really central to reducing smoking in pregnancy rates. We also want to see a new target for reducing smoking in pregnancy to get us on track to reach a smoke-free 2030. So the current target expires in 2022. We need a really ambitious new target to drive performance and activity if we're going to achieve that smoke-free 2030 ambition. And our proposal for what the new target should be and the rationale is set out in more detail in the report. We also want to see a national strategy for improving the provision of smoking cessation training to health professionals who treat pregnant women. So currently there's major gaps in the provision of this training, and it's really vital that we ensure health professionals have the knowledge, skills and confidence to support pregnant smokers to quit. We also want to see more work to develop interventions to address relapse to smoking postnatally and smoking among fathers, partners and other high prevalence groups. We know these are really big challenges, and we know that, for example, women who live with smokers are much more likely to be exposed to secondhand smoke, or it's much harder for them to quit. But we don't have proven interventions or approaches for addressing these issues, so we need to see a much stronger focus on developing these interventions and sorting that. And then finally, we want to see much more use of financial incentives, which we know are effective for supporting pregnant women, particularly those from more deprived communities, to quit smoking. And Professor Cherilyn Notley will talk a little bit more about this later on. Thank you very much. That's it from me.
Okay, thank you for that presentation and for giving us the key points from the report, John. Can we now move on to Joe Churchill, who's obviously the Public Health Minister, who I invite to give us her view from the government in terms of the agenda and also looking at the report in some detail. Over to you, Joe.
I gaily muted myself, did I not? At what point did you lose me, or did you not?
Completely, I'm afraid, from the beginning.
Right. I said thank you for inviting me, and thank you very much for asking me to give the government's view, which I'm afraid I will pepper in this particular APG with some of my personal desires for where we get to here, because I do think it's of vital importance. I welcome the report, particularly the chance to build back better after COVID, which I think we have a huge opportunity to do so many things. One of the positives, if there is to be drawn from COVID, is how people have worked together, how people have broken down barriers, and how people have just moved things aside in order to deliver for patients. And I think we ought to seize that opportunity in this area. Preventing smoking in pregnancy is something that I hold dear to my heart, and I am particularly keen to see us progress further. It's fantastic to see the collaboration between the two APPGs on this report, and the APPG on baby loss. I remember only too poignantly colleagues like Will Quince and Victoria Prentice and Antoinette Sambach, who's no longer in the House, and listening recently to Cherilyn. They are very moving contributions. So anything we can do to help give parents support and to help them avoid, in any circumstance, losing their baby is something I feel we should do. The report is incredibly timely. The department is gathering evidence to further develop the proposals for the tobacco control policy, which will help us achieve that ambition to be smoke-free by 2030. You challenged me to make sure that I wasn't moving the date at all, Bob, at the beginning, so I will confirm now that it is this summer 2021, when we will be giving you that plan. It will be heavily focused up in levelling up, and I think John brought out in the report there some of the stark variation, because we know that 40 out of 190 CCGs actually have got below the 6%. Now, if you like, what that means is, as the overall percentage difference is 10.4 last year on the last figures we had, that actually the variation, as the graph showed, is quite enormous. We have got a long way to go in certain areas, which is why these things need to be targeted, so that tackling smoking in pregnancy, where those rates remain stubbornly high in some of our most deprived communities, is absolutely critical. Because we know we've made some progress over the past 2 decades. I mean, good progress actually, in addressing the harms from smoking. The UK remains a global leader in tobacco control, and adult smoking rates are at their lowest levels at about 13.9%. The reducing smoking rates has been a public health success, but there is further to go, because it particularly saddens me to learn that 1 in 10 women are still smoking at the time of their delivery. In certain parts of the country, rates are higher than that. For example, those rates in northwest London are 2.1, and up in the northwest in Blackpool, 23.1. Now, you know, when you have that degree of differential, that actually targeting things regionally is the way to start to actually get a more even distribution across the country. So securing a reduction in the national average is not good enough here, in my view. We need to make that concerted effort to reduce rates in every part of the country, as this is the only way that we will make sure that every child has the healthiest start to their life and can improve the health of mothers and children and the broader family. Because in my experience, when I've met mothers on the successful delivery of the smoke-free pregnancy programme in Greater Manchester and elsewhere, actually targeted work gives us much more bang for our buck, because you get not only mum and the baby having better outcomes and life chances, better birth rates, birth weight, and so on, but invariably there is a supportive partner there, whether that's a member of the close family or indeed birthing partner, that is also often encouraged by smoking cessation midwives and others to help mum go on that journey of giving up by giving up themselves, and that helps baby's environment completely. So it's always really good to hear firsthand about people's experience and how that creates a real difference in their lives. Innovative programs like this use a range of methods to help women stop smoking and address health inequalities, and that targeted incentive scheme and the data from that combined with enhanced support is really interesting. I'd also like to mention some of the national work that's helping to take the rates down, and work which is ongoing over the next few years. As you know, Helping Mums Stop Smoking is embedded within that maternity transformation programme designed to improve maternity services and patient pathways. Also, the long-term plan commitment to help mothers stop smoking, and NHS England and Improvement is working with early implementator sites across England to begin piloting stop smoking interventions with inpatients and pregnant women. They're also working with NHS trusts in each region to prepare them for a national rollout by 23-24. Despite being paused back in March 2020 due to the COVID-19 outbreak, additional guidance has also been published to safely resume the carbon monoxide testing during antenatal care as part of the Saving Babies' Lives care bundle. Now, one of the reasons staff may potentially not be bringing up the topic of smoking in pregnancy is a lack of confidence and knowledge about how to approach a sensitive subject. So we've provided 150,000 in additional training for midwives to build up their skills in this area. And this is so that they can give targeted advice to women during antenatal appointments, because for me, this is one area where you make every contact count. Actually, it doesn't matter who can hold your hand and direct you into those services. Everybody needs to give it a go, because if a young mum or even an older mum isn't ready at a certain time, perhaps they're ready a few weeks later in their life when their pregnancy is developing. Now, reducing smoking during pregnancy is an area of focus within the NHS Maternity and Neonatal Safety Improvement Programme, and 37 of the NHS organisations have undertaken initiatives to increase smoke-free pregnancies. That does mean that there's an awful lot of work still to go, but it is a huge move forward. And in addition, 6 safety improvement networks are focusing on this clinical area as part of their system-wide improvement. This is all really good news in working towards further reducing smoking rates during pregnancy across the country. But I would like to see us go further. I would like to see the new tobacco control plan include proposals which help us achieve smoke-free pregnancies, particularly across the levelling up agenda. And I would, from my own point of view, and this is where people text me wildly saying, nobody's asked you to say this, I would love to see us be more innovative. So as we digitise the Red Book, for example, why can't we actually help direct people to smoking cessation services through the Red Book? Or perhaps even make every contact count and use things like mother and toddler groups and other areas where naturally maybe we haven't caught mum during her first pregnancy, but we could do something a little more with a second pregnancy, because I don't need to tell anyone on this call where babies come from, but they have a habit in coming into your life in more than once. So if we can't catch somebody and help them the first pregnancy, we certainly should be able to make every contact count and catch them at a second go. So I thank you very much for this report and for holding my feet to the fire. And I look forward to working collaboratively with you to ensure that we tackle smoking in pregnancy and achieve a smoke-free generation by 2030 by driving those annual rates down. By the way, and this is just a question that I'm asking because you're probably much more informed than I am, in a bounty pack that gets given out to a new mum, do we include in there details of the local smoking cessation service? Because if we don't, maybe we could. And I'll leave you with that thought.
Well, thank you, Joe, for that speech. I thought we were supposed to ask you the questions, not the other way around. But thank you for that speech.
No, it's meant to be a dialogue.
It is indeed. And actually, our next speaker may be in the position of being able to answer that particular question. I know that you're extremely busy and may have to slip away, and so we understand that. Just as a reminder for colleagues on the call, please put any questions you've got in the chat function, or if you've got an observation to make, we may come to you as well. But we're now going to come, which seamlessly on. I mean, this could be prompted by the minister. Our next speaker is Becca Scott, who's the Public Health Prevention Lead for the North East Local Maternity Systems. Becca's going to talk about the importance of working regionally to drive down rates of pregnancy. Drive down rates of smoking in pregnancy, not drive down rates of pregnancy. That may happen naturally anyway under the pandemic, but let's see. Over to you, Becca.
Thank you, and thank you so much for inviting me here today. I'll obviously keep this quite short because we've only got a few minutes to go through it. So I'm Becca Scott. First of all, I'm a midwife and a health visitor. And in 2018, I went into the role as the North East Local Maternity Systems Prevention Lead. And in the North East, which you can see on that map there, we have 10 CCGs, 7 foundation trusts, 12 local authorities. We have a population of around 2.66 million, and we have just under 26,000 births in the North East. Local maternity systems, for those that don't know, England is split into around 47 areas and each have its own local maternity system. And the point of them is to really deliver on the maternity transformation programme and the Better Births agenda. So that's where my post came about. So, as I said, more recently in 2018, I've been in post, but prior to that, there's been so much work done in the North East on this agenda, and I can see that keep popping up into the chat bar there. Fresh were put in place in 2005, and they've led a really comprehensive tobacco programme. And in 2007, they had their first regional summit around smoking in pregnancy and really start to focus on this and give it the priority that it really deserves. So forward and on a couple of years from there, Newcastle University undertook quite a detailed insight work with maternity staff, and really from there Fresh were able to commission the Baby Clear approach in the North East, and that really concentrated down on Have a Nice guidance, which had come out in 2010, making sure that the CO monitors available for women to be having that regular contact, and making sure the midwives feel confident and trained in what they're undertaking. As I said, the LMS more recently have been leading on this, and we're really well embedded within maternity services. As well as said, we've got 7 in the North East. So much of our work has concentrated on delivering on the Saving Babies Lives Care Bundle, where they have the ambition to reduce stillbirths by 50%. And we've made sure that our work is really embedded across the system. But we didn't recognise what needed to be done until 2018, when we undertook a large audit in the North East of maternity services. And on this next slide, you can see some of the key findings that we had. We had a stakeholder event later in 2018 to discuss this roundtable event, to see what did the agencies we're working with feel needed to happen. One of the key themes that came out of all of this work was around inconsistency. Baby Clear was perhaps seen as a pilot, and really it's nice guidance, and it's something that needs to be embedded into practice. As you can see, there's a large amount of agencies that we work with, and we do come together for this same reason, but obviously it's working out what is important to that organisation. So for us at the LMS, it's that we want less than 6% of pregnant women at time of delivery smoking by 2022, and then it'll be 5% by 2025. But some other organisations are really focused on the Saving Babies Lives element. Some places it's around smokers' morbidity, some's around reducing inequalities. Quite often it can be a personal vendetta against smoking in pregnancy that they want to see change. And quite often it's around the financial cost savings. So it's finding the hook for each of those organisations to be able to work together for a common vision. So as I said, there's been a lot of work happening around the consistency side, and it's had various elements. So we've looked at things like data collection, training needs, and really trying to have the same approach right across the region. For all the Baby Clear had been in place, as I said, it hadn't really been embedded, and for all its nice guidance, sometimes it just wasn't happening like it should be. So working together with lots of different people across the region and women themselves, we developed a regional tobacco dependency and pregnancy pathway, and with that there's a script to give the staff the confidence to be able to have those hard-hitting conversations. We wanted to make sure that there was plenty of equipment available for staff, and that they knew where to refer women to if they didn't have that service already embedded in their trust. All the work's being governed quite rigorously through different places. So the LMS boards, we have an LMS prevention governance group. It definitely sits within the ICS prevention board really closely, and actually I'm managed by a director of public health, because this really does need #1 priority out of all of our work. We also cascade information out to our public health midwives. They're really key in this. They're the people that are doing the work, making sure that it's happening in practice, identify the needs, really any issues come back up to myself so that we can look at it further right across the system. This has been really important. 2019, the ICS, the Integrated Care System, wanted to look at a project around system leadership, and we just happened to be around at the right time to take this issue forward with them. So they've been really working with us and supporting us, and have actually made sure that all the Foundation Trust chief executives sign up to this agenda and make sure that the work is definitely embedded into practice, and that it's something that's regularly reviewed on their boards. So the work has been prioritised right through the system, as I said. So we've got it at this high level ICS level. We've also got it in the health and wellbeing boards in each of the local authorities. We have tobacco and dependency pathway groups, so they can be regional or they might be focused around that local authority or foundation trust area, making sure that everybody's working together for that same purpose, no matter what their own actual target is. This has ensured that the NICE guidance has been embedded into practice, and we've seen significant improvement around this. The training is really consistent. We know what we want and how it's to be delivered. The barrier towards this is around releasing of staff to be able to attend the training, which has been particularly difficult over the last year due to the pandemic. However, we've also had the opportunity to really influence other parts of the system. So health visiting in early years are really keen to work on relapse prevention, and they formed a small group to start looking at a pathway of care or best practice to follow the maternity pathway on, because we know from our insight works with women, quite often they actually stop smoking in pregnancy and always plan to start again, not understanding the full effects of that on the smoke-free family. So we've got that happening. We've seen significant improvements in routine carbon monoxide screening, and there's regular follow-up. When women don't engage with the services that are offering that support, it's then fed back to that referring midwife so they can then follow that up. We've still got a long way to go with this, but we can see some improvements. We now know that we don't have any women down as unknown pregnant smokers, and that's at around 4 or 5% of all our SATOD data was unknown. So that doesn't happen now, and we ensure that they are actually smokers, because we did have women that were vaping only classed as smokers at one point, which obviously affected our data. There's been a steady decline of smoking at time of delivery. So we were at 16.3% in 2017 to 18, and in the last full year that had reduced to 15.2%. So we still definitely have a long way to go towards that 6%. But now that we've got the consistency there, we have some real clear vision of how we can move this forward and have that really targeted approach through the delivery of the long-term plan. That's all from me. I suppose my only ask, and this kind of goes off the back of the report that's been helpfully released today, is that we really do think about the tobacco control, how we really influence the young women coming through schools and what they're seeing with their parents, how tobacco looks. So what does a cigarette look like? The package is awful, but what is the actual cigarette looking like? There's so much more we can do around media campaigns. And I think it's fantastic that we're looking at this together right the way through the system. Thank you.
Okay, thank you very much, Becca, for that presentation. Can I remind colleagues, if you've got a question, please pop it in the Q&A. We've got a lot of comments that have been made in the chat function, but not many questions. So it'll be helpful if anyone's got a question, put it in the chat function, and we'll come to that. So our next speaker is Misha Moore, who is a National Speciality Advisor for Obstetrics, Public Health for NHS England and NHS Improvement. Misha is going to talk about the NHS's contribution to reducing maternal smoking via the NHS long-term plan and collaboration with the public health community. Over to you, Misha.
Brilliant. Thank you very much, and thank you for asking me to speak. I'd just like to thank ASH for all their very hard work on such an important report as well. I think we're running about 20 minutes late, so I will speed through this. NHS England and Improvement have been involved in the smoking and smoking and pregnancy agenda for some time now. We published the Saving Babies' Lives Care Bundle that you've heard about in 2016. We refreshed it in 2019, and we've kept that very important element 1 around reducing smoking in pregnancy. There's been loads of work done since then. We've had continued engagement with the Care Bundle. In our recent tracker survey, almost all providers who responded to us reported they were carrying out some kind of improvement initiative to address element 1. We've heard from the Minister about the government funding that was released for training. We've also collaborated with Public Health England and Health Education England, who have developed online learning resources which are now freely available to all midwives to support them with delivering very brief advice on smoking. We're continuing to progress the smoking and pregnancy agenda through the long-term plan. For those of you who don't know the nitty-gritty of the long-term plan, there's a commitment that by 2023, all people admitted to hospital should have access to NHS-funded tobacco dependence treatments, and that model will be adapted for pregnant women and their partners with focused sessions and treatments. So huge opportunity there, huge opportunity for a more holistic approach, and to complement and fill any gaps in the current service provision from local authority commissioned stop smoking services. And it's really, really important because we know that people are up to 4 times more likely to stop smoking with specialist support, but they also need support from those around them. The NHS England and Improvement Prevention Programme is leading on this. It's going to be a phased rollout across all integrated care systems until 2023 to 24. It's going to be tested and refined, as we've heard, hopefully in 3 early implementer sites over the next 9 months. And the recommended model is based on the Greater Manchester Smoke-Free Pregnancy model, which has also been alluded to. And that model incorporates NICE guidance with bespoke behavioural support, nicotine replacement treatment and intensive face-to-face treatment. And they've had really promising results, increasing identification of women who smoke, referral of these women and quit rates almost doubling since implementation of that model. So there are huge opportunities to make progress with this, and they were established pre-COVID. We're very lucky to have the precedent which we can now build on going forward of a very collaborative approach to delivery in conjunction with our partners and stakeholders. We particularly have worked very closely with Public Health England. The long-term plan prevention commitments and elements 1 of Saving Babies' Life Care Bundle was developed in conjunction with Public Health England. Public Health England leads on the Prevention Workstream 9 of the Maternity Transformation Programme, and they participate in our prevention board as well. They've appointed regional leads for tobacco that will be working in tandem with the NHS prevention leads to support delivery of the long-term plan. And we continue to work with the national team on various issues, modelling outcomes, effective service delivery, best practice advice, evaluation of outcomes. We also routinely work with other partners in maternity. We always work with our service users, maternity voice partnerships, and we're very, very fortunate to have the Smoking and Pregnancy Challenge Group, which is such an important forum to bring together stakeholders for collaborative working and learning across the system. So loads and loads of opportunities, but I think I'd be foolish not to mention some of the challenges, because there are huge pressures on the system, both during the pandemic and envisaged during recovery as well. There are changes to the way that all services are provided, and they've affected both maternity and stop smoking services. We've heard about the pause in carbon monoxide testing and the subsequent guidance to resume that, but we know that there are pressures on the system, and due to various different pressures, that hasn't been universally achieved. We have a challenge in meeting the long-term plan commitments because we've already had to pause the pilots due to COVID and reconsider timing. And we know that in recovery, systems will need to prioritise services. And so as we allocate funding for the long-term plan, systems will need to ensure that smoking and pregnancy is a core component of plans and that it's prioritised according to need. We also have to be mindful that there will be additional asks on maternity services on top of COVID pressures, particularly in relation to maternity transformation and safety, following the recent publication of the Ockenden report. And there are some uncertainties around the future of collaborative working, because there are uncertainties around the future of the health improvement functions of Public Health England and how the public health system will look at the end of this. For me, as the report supports, one of the most effective mechanisms mechanisms of reducing smoking in pregnancy is by reducing the number of women who enter pregnancy smoking in the first place. So lots of challenges, but we know that this is the single biggest modifiable risk factor for poor pregnancy outcomes and a significant influencer of health inequalities. So there still remains a lot of enthusiasm to address this. We've seen this in the engagement from our pilot sites, despite the pressures they've been under through the pandemic. There's already a lot of good practice in the system that we can continue and that we can learn from. And there are lots of opportunities through COVID. COVID has shed a spotlight on health inequalities and prevention, and system working has come on leaps and bounds during COVID as well. So there will be silver linings. I think we just need to push through. We need to continue to collaborate. And if we can ensure that smoking in pregnancy is incorporated into plans for recovery in a practical and sensible way, I'm sure we can make progress. Thank you.
Thank you, Misha, and thank you for endeavouring us to get back at us on some degree of track in terms of time. So our next speaker is Professor Cherilyn Notley from the University of East Anglia, who will summarise the evidence for financial incentive schemes and set out the case for supporting women who've quit smoking during pregnancy to stay smoke-free after birth. So over to you, Cherilyn.
Thank you very much for the opportunity to speak to you today on our Cochrane review, which was published in 2019. I'm just going to attempt to share my screen and hope that you will be able to see that. Can you all see my presentation?
Yes.
Okay.
Yep.
It seemed to have jumped right forward, sorry. Apologies. Okay, so I want to focus today on the evidence for the effectiveness of incentives for supporting cessation attempts during pregnancy, and also consider the role of incentives for addressing inequalities and the possible additional benefit of the impact of financial incentives for supporting not just cessation attempts, but also sustained smoking abstinence, i.e. long-term relapse prevention. So as we've heard, rates of smoking in pregnancy have not significantly declined in recent years. While low in some areas, there are other areas where rates remain stubbornly high. There's a clear link to the most deprived areas in the UK, and incentives may be one way in which we can reach out to those who have so far remained difficult to engage in cessation attempts, a tool perhaps to help us access women for whom there remains a cultural norm to smoke within the family, where partners perhaps are continued smokers, where there's limited social support to quit, and hence where there may be little internal motivation to quit. So for these women, there's perhaps a need to go beyond what's recommended as part of NICE guidance and consider alternative forms of support. The Cochrane Review Cochrane Reviews in general are considered the gold standard source of evidence review for policy makers and practitioners, since they follow extremely rigorous and transparent methods. Our review of incentives for smoking cessation reviewed evidence from randomised controlled trials, recruiting general population smokers and also pregnant women who were explored as a subgroup within the analysis. Our key outcome of interest was whether incentives reduce the prevalence of smoking at the end of pregnancy and into postpartum follow-up. So we included in the review 9 trials involving pregnant women representing 2,273 participants. Taken together, it was clear that the trials, 8 of which were conducted in the US and 1 in the UK, demonstrated a clear benefit overall for the incentives groups versus controls. This evidence suggests that women receiving incentives are twice as likely to quit compared to those in the non-incentive groups.
Hi, Cherilyn. Sorry,
Hi.
I think your slides, I'm just seeing the first slide. They don't seem to have moved on.
Okay. Can
sorry.
you, I'm having problems sharing in that case. Are you able to
Yeah, do you want me to share instead?
share? Thank you. Apologies, everyone.
As we're running out of time, Caitlin, do you want to carry on and John will
Yeah,
catch up with
I'll
the
just pull them up.
I will. So we're on slide 5, John. Further findings from our synthesis didn't allow us to ascertain particularly which particular incentive value might be most effective, but 3 trials within the review specifically explored contingent rewards. And by that I mean offering incentives based on abstinence outcomes and offering increased incentives amounts for ongoing continued abstinence. So these 3 trials all favoured the offer of conditional payments. And importantly, the large UK trial led by David Tappin reported no particular harms or disbenefits of offering incentives, although the potential for gaming clearly is something important that needed to be monitored. Okay, next slide. So overall, we concluded with moderate certainty evidence across the 9 trials amongst pregnant women that the efficacy of incentives at longest follow-up was confirmed at or around the end of pregnancy. Findings from our meta-analysis in general population studies also led us to believe that incentives continue to have a significant impact even beyond the period of time in which they were offered. So we concluded overall that incentives offer an important route to smoking cessation that is effective and may add value to a comprehensive public health approach to reducing smoking prevalence alongside other forms of cessation support. So next slide, I just want to present to you a very brief example of an applied case study. This wasn't a trial, so it wasn't included in the review, but in 2017, an evaluation undertaken by South Tyneside local public health team evaluated an incentive-based cessation scheme. This scheme offered Love to Shop gift cards to pregnant smokers who reached key dates along the quit pathway, with the value of the gift card increasing the longer the woman maintained a quit. The incentive scheme was delivered from local children's centres, and key cessation outcomes were that remarkably 63% of women were quit at 4 weeks compared to only 9% of women who weren't offered a voucher. 29% of those receiving vouchers were still quit at 35 weeks compared to none of those who didn't receive vouchers. And the scheme was thought to be particularly effective at tackling inequalities by achieving good quit rates in the bottom 2 deprivation deciles. It was also highly valued by service users who felt that being able to offer pregnant women something positive and helpful alongside standard care was something really important. And really importantly, since the scheme has been in place, South Tyneside's rates of smoking at time of delivery have dropped by almost a third, from around 20% in 2017 to around 14% in 2019. So one particularly important consideration when considering the effectiveness of incentive-based interventions is assessing the ability of the intervention to target those populations most in need. Incentives seem to work, it's hypothesised through the process of operant conditioning and rewarding positive behaviour change, but also the idea of delayed discounting. So often for young women quitting smoking, the long-term preventative health benefit can seem too distant to be that meaningful. Offering a reward is a way of discounting the delayed reward of health through smoking cessation by bringing that reward much closer to home, i.e. making the reward contingent on behaviour change at the time it's actually happening, and offering a financial incentive to those who are most in need may be the most effective approach. And finally, I just want to consider briefly the importance of incentives for sustaining long-term smoking abstinence or helping to prevent relapse. So there's currently no routine support for sustaining smoking abstinence once a woman has quit. The policy focus on smoking cessation in pregnancy is obviously really critical, but it is staying smoke-free for good that has the most important cancer prevention benefits for mothers and for babies in terms of preventing secondhand smoke exposure and risk of sudden infant death. So I just want to take this opportunity to raise awareness of our Baby Breathe trial funded by the National Institute for Health Research. We're opening recruitment to the trial in the next couple of months. We'll be recruiting women who've quit smoking during pregnancy across England and Scotland with the aim of supporting them to remain smoke-free postpartum. Self-incentives form a really important part of the relapse prevention intervention that we will be testing in this trial. So you can read the full Cochrane review or a summary online via this link, or if you prefer to listen to your evidence summaries while taking your daily exercise, we've produced a podcast that you can access. And if anyone is interested in the Baby Breathe trial, please get in touch or have a look at our website. Thanks for your time and attention.
Okay, thank you, Caitlin. No,
I'm sorry about the slides.
the concept of listening to the presentation whilst indulging in exercise, I think, is something that is unique. I haven't heard that one before. So, can I introduce our final guest speaker, which is Alex Norris MP, the Shadow Public Health Minister, who will share with us Labour's reflections on the importance of tackling smoking in pregnancy. Alex, over to you.
Cheers, Bob, and I'll be succinct so that we've got a chance to hear thoughts from those who are watching. But thanks for having me, and thanks to you and Cherilyn and Jeremy for giving me an opportunity to speak and to give some reflections. You know, as we look at rebuilding the public's health going into this next decade, smoke-free is one of those foundational projects, I think, alongside grappling with obesity, particularly in childhood, alongside the review of the Gambling Act, the scope to be transmission-free of HIV by 2030 is vital. That smoking, I think, plays a really foundational role in the changes that we plan to make. My interest in this area, particularly around smoking in pregnancy, came as when I was portfolio holder on my council responsible for public health and smoking cessation. I spent a lot of time with mums-to-be and young mums finding out about smoking pregnancy. And it's the great thing about politics, as the MPs on the call will know, is that if you wait for long enough, people generally tell you the answer. But hearing from those people what made them still smoke, and I kept them because it was quite striking. Whether it was the fact, well, my nana did and my mum did and they were fine, whether it's because quitting smoking is really hard at the best of times, never mind when you're stressed, or a really particular one around, and it can't just be particular to Nottingham, but in John's presentation, he showed the link between smoking and pregnancy and then baby's weight, and obviously it has a negative correlation, but actually the perception that a smaller baby would mean a less painful birth. So it's incredible, those sorts of reasons that the people were making those decisions. And also we got some of those reflections about what might be better ways to support people to stop smoking. So it was good services based in their community, the importance of peer-related services too. It was made very clear to me, a man in a suit, that they didn't need me to be putting leaflets through their doors telling them what they should do in their pregnancy, which I thought was always a good reminder about who they listen to. And certainly in every contact counts method, as Joe said, we absolutely would support that. And I think what we've just heard from Caitlin was fascinating around incentives. I think that is, being really candid amongst friends, that is exceptionally squeamish territory politically. But I always take the view that certainly in something as important as this, what works is what works. So I think it's absolutely crucial that we talk about this, that we understand the emerging research and then think about how that might be turned into public policy. I won't labour on the public health grant for very long, Bob, because I don't want to politicise things, but we do have to understand the impact of decisions made around the public health grant in recent years. And, John touched on that in his report. And as we go through and rebuild smoking cessation services, there's a question in the comments saying, could we have a world-class service in this country? Well, absolutely we can. But we can't have a world-class service if we have middle of the table or bottom half of the table levels of investment in it. So there has to be a connection between what we want and what we're willing to put into it, which of course leads us really neatly into the tobacco control plan. We're really pleased Joe's committed to that, and you got her to recommit again to a sense of the when on that. And that is a great opportunity. This will be the plan that gets us to smoke free. So this is it. This is the big final shove. And what we're looking for from that is a granular approach. And again, we heard that from Joe today a little bit. So that was very pleasing to hear, about understanding that it is still particular communities. And I say that as living in a smoking prevalent community that have the greatest challenges. So we need specific and targeted interventions. Similarly, that we know it's people with certain characteristics. Today we talk about maternity, so we need to have specific focus in the ways in which we're discussing, but also around mental health, targeted around younger smokers, stopping them getting underway at all. That's what we're looking for from a strategy that's bold, very ambitious in terms of how it intends to do that, with this lofty 2030 goal in mind, and then resourced in order to do that. So I think at that point, Bob, that was a pretty quick omnibus of where I am, but I'm conscious of time. But great to be here. Really interested to hear what we've heard from the speakers, and I think the high level of political consensus that's developing, as we saw in the recent debate in Parliament, is a good sign and a good bedrock. There are still things we differ on, and that's no bad thing. But hopefully we can come together to get towards what I think is a really important thing to do.
Okay, well, thank you, Alex, for those remarks. And I'm sorry you're getting squeezed at the end
That's okay.
of the speakers, but I think it's important to hear from the presenters as well as the politicians. Jeremy's had to leave, unfortunately, because he's got another meeting starting at 3:30, so he's left us. So I'm going to hand over to Cherilyn for I think from some closing remarks and dealing with the wrap up. So Cherilyn.
Thank you, Chair. I hope you can all hear me. My connection has gone a little bit glitchy, so apologies if I drop out. Because we're running over, we've taken a note of all of your questions and comments that you've put into the chat. Thank you very much for all of that today. And what we'll do is we'll collate those and we'll get answers back to you, because I don't want to keep anybody longer than they really have to today. But I'm really grateful for the opportunity to speak to you very briefly and to collaborate with the Smoking Health APPG today. Being somebody who has lost a baby, not because of anything I did or anything any lifestyle issues that I had, can tell you now, it is the most painful experience that somebody will go through. And had I been somebody who, even though I was addicted, had been smoking during that pregnancy, I'm not sure I could ever forgive myself. So even though we're talking about a lot of statistics and numbers today, each one of those mums who has had to experience that will then have to be experiencing what could I have done differently, and the guilt that goes along with that for the rest of her life. She will never get over that feeling. So we must be absolutely sympathetic when we're dealing with all the stats and all the good work that's happening. We've got to remember and drill down to everybody's single personal story to make sure that they are not being forgotten as part of the narrative. And I'm sure everybody who's working on the ground absolutely understands that. I'd like to give a huge thank you to all the speakers today. Firstly, John Waldron from ASH, and from Minister Churchill, from Becca Scott, Misha Moore, and Professor Caitlin Notley, and also Alex, last but never least, Alex. I'm really pleased that as being part of the baby loss APPG, we had the baby loss debate in Westminster Hall back in October as part of the Baby Loss Awareness Week. And it was the first real chance that I got as a brand new MP to see how well opposition parties can work together when it is something as important as this. And it was a very moving experience to be part of that debate. And I'm sure, having spoken to colleagues on all sides of the House, they all felt the same. It is so important that we get this right for young mums, for all mums, and for all families, and for, of course, for all the babies that are affected by this. And absolutely, I'm sure it is absolutely something that we can put party politics aside, listen to the people on the ground who are dealing with people every day, listen to the midwives, the health workers, families, mums, everybody involved, and we will all work together to make sure that we do our very best to hit that target. But it is just a target. Every baby's life that we can save through this is absolutely priceless. Thank you again for everybody. Thank you to Chair Bob. I'll hand back to you to close. Thank you.
Okay, thank you, Cherilyn, and thank you for sharing your experiences, because I know that must be absolutely personally horrendous, and something that I know that all on this call and beyond will have every sympathy with you in those circumstances. Can I thank everyone that's participated, all the presenters, all the politicians, on behalf of parliamentarians in this call. Thank you to all the health professionals and others that have helped participate. As Cherilyn says, we will take up the questions and points that you've made in the chat function and then obviously reply to them appropriately. So without further ado, thank you for your attendance and for everyone who's welcomed this particular report, and I wish you all the best for the afternoon. Have a good day.
Well done. Yep.